Health Town Hall program. My name is Elise Burr. I'm the director of the NMU Center for Rural Health, and the program is being hosted this evening in partnership with Dr. Kelly Kam, epidemiologist and assistant professor in the Department of Kinesiology and Integrative Physiology at Michigan Technological University. I'd like to take a moment to welcome tonight's guests. Our topic for this evening is community health workers. And the guests this evening who are joining us are Shannon Lewinsky, Chief Executive Officer for Everyday Life Consulting, Susan Kauppi, Case Coordinator, CHW and Michigan ACE Master Trainer for the Western UP Health Department. Thanks, Sue. Audrey Surlis, Project Manager and CHW Instructor here at the NMU Center for Rural Health. We also have Judy Brugman. She is also a CHW Community Health Worker Instructor, also here at the NMU Center for Rural Health. And we also have Leanne Espinoza joining us. She is the Maternal Infant Health Program Manager and Deputy Public Information Officer at Luce Mackinac Elder Schoolcraft District Health Department. Thank you, everybody, for joining us tonight. So glad that you could be on about this very important topic. Kelly, do you want to get us started and talk a little bit about social determinants or drivers of health?
Absolutely. So this is a little bit of our continuation of our talk last month. So about 25% of our individual health comes from our healthcare, but about 60% is actually driven by factors that are related to our social, our economic, and our political and physical environment. And so all those things that are around us that we live in and that we play and work in, and these are those social determinants of health that we discussed a little bit last time. And because social determinants are not evenly distributed both within and between our communities, these are also big drivers of the inequities that we see in health across our communities and between our communities. And so when we think about this, they're big drivers of our health, they're big factors or determinants in our health, but our healthcare providers really don't have time to address these when we have such limited time with a doctor or a healthcare provider in those appointments at the office visits. So there's a lot of different ways that we're trying to figure out how can we address these factors and help people live a healthier life. And community health workers are one of these ways, and we're going to talk about these tonight. So I'm so excited to have our whole group of panelists here. And with that, we're going to just dive right in and we'll hear from Shannon. So again, she's the Chief Executive Officer for Everyday Life and Consulting. So thank you, Shannon, for joining us.
Thank you. Shannon Lewinsky, Michigan Community Health Worker. Excited to be here. I'd explain a little bit about who we are as community health workers. So our national workforce is a Department of Labor classification. American Public Health Association definition defines us as a community health worker, is frontline workforce. We're trusted. We have close relationships to our community. We have trusting relationships. We serve as a link, an intermediary. We help build capacity within our communities. I'm going to share a little bit about our 6 pillars as well. So this is a new way that we've been defining the workforce from our National Association of Community Health Workers. Our 6 pillars are: number 1, that we are a unique workforce. Number 2, we're community-based. Number 3, we're historic and extremely diverse. 4, we are cross-sector. 5, we are proven. We are evidence-based. And 6, we're very precarious.
I think we've been doing a lot more work more recently, I think, with community health workers, at least in the Upper Peninsula region. I know that historically there have been community health workers in clinics at federally qualified health centers. More recently, the last few years, they've been embedded at some of the hospitals in the Upper Peninsula. Not enough of them, if you ask me. So we need to keep spreading the word about community health workers. But Shannon, can you talk a little bit more about where community health workers could work, including outside of the medical setting?
Yes, I would say Michigan is pretty unique in that the majority of our CHWs are employed by community-based organizations. More recently, as we have embarked on exploration of certification in the state of Michigan and fee-for-service Medicaid payment models, we are seeing rapid expansion of employment within health departments, hospitals, private practice, in community mental health settings, and also in schools and academia. Community health worker, we have over 150 titles, represent over 1,000 cultures. So essentially, when we were asked that, I mean, you could work anywhere if you're delivering frontline public facing, relationship-based work, helping to navigate resources or connect one another. As far as like application assistance, it's a very common, I would say, practice for community health workers. But really being, again, that local, culturally competent tie, being, I would say, aware of the resources that are hidden, things that I might know in my community, you will know in your community. And we define community very local. It's my street, it's my neighborhood, and also the city and county that I live in.
And can you talk a little bit about what's happening at the state level right now? We know that there's different organizations that are using community health workers, providing some of the training that's available to them. Can you talk a little bit about big word reimbursement and what's coming down the pipeline as far as that goes?
Yeah, this is an exciting space for us in Michigan as we integrate community health workers more and more. So I've had the privilege of being on the 4 work groups over the last 10 years in Michigan, and most recently on our CHW State Advisory Committee. That work has sundowned as we are again embarking on certification and fee for service. Thus far, what we've been hearing is that everything's been approved through Michigan. They're waiting on CMS approval, but the code should go live in January-ish. But definitely get connected, stay connected. I know Elise will have the first and foremost of the information as we become abreast of it. But let's not also forget that we in Michigan are also unique in that we have both health home models, we have doula reimbursement, we also have direct care worker reimbursement, independent community living supports, peer support specialists, recovery coaches, and Medicaid managed care contracts. And so we're very fortunate in Michigan to have this braided funding stream. And so when you integrate and you operationalize your program, it's very financially sustainable.
And Shannon, can you talk for a minute about everyday life consulting and the services that you're able to provide community health workers kind of before and after certification takes place?
Mm-hmm. So Michigan, or Everyday Life is Michigan based rather. We are a national CHW training and consulting firm and technical assistance provider. In a nutshell, essentially, we're there to help at all aspects. So from training to network building to strategy, technical assistance, coaching and mentoring. We have a big philosophy on meeting people where they're at. And so with us having a national team, that means there are individuals who have offices that provide that satellite work. And so partnership with individuals, and organizations like the Northern Michigan Center for Rural Health to really, again, meet the community where they're at and expand the services at a local level with local leadership. The other thing that we do is we provide advocacy. So I myself am the policy chair for the National Association to really help make sure we're bringing visibility and I would say providing context to the unique work that we do, especially in a rural area. One of the blind spots when you see these fee-for-service codes is that they have to be delivered within face-to-face within the 4 walls of the organization, not taking into consideration that my work in a rural area might take me 200 miles from the office, which is then uncompensated. Thus, where the braided funding comes into play and really helps, but still more advocacy work to be done, again, to give visibility to our work in a rural community.
And I think it's also important to note that you offer some continuing education modules for people who are community health workers already and wanting to maintain that certification, but also to expand their knowledge, in certain areas. And one of the things that I really look forward to working with you on is taking a look at what modules might be more relevant to the rural settings and kind of selfishly the Upper Peninsula, Michigan, but trying to share some of those solutions with other community health workers, and just being able to ride on each other's successes have that communication and that access to education to really look at solutions like that.
Yes, no sense in recreating the wheel, right? We have access to over 50 learning pathways. Now, it gets a little bit jargony because sometimes it's called micro-credentialing, upskilling, continuing education credits. But essentially, to all the employers listening and even the CHWs, this is a skilled trade. I highly encourage that you are continuing your professional development and really challenging yourself in new areas that you might not have done some professional development in. Also knowing that a lot of our training is unique, and I know Audrey and Judy will speak on that a little bit later, but it's a lot of fun, and I'll kind of leave it at that.
Thank you, Shannon. Next, we're going to move on to Susan Kauppi. Susan is a well-seasoned community health worker on the western side of the Upper Peninsula, working at the Western UP Health Department, and we've had the pleasure of having Susan in our training classes back in June, which seems so long ago now that it's the end of October. But thanks for joining us tonight, Sue.
Well, thank you so much for having me tonight. So being a CHW is really unique in that you can provide direct services to people. And the reason I really wanted to become a CHW is because I've been doing that for years and years, and I've been involved in years of home visiting, and it's such an honor to be able to hear people's stories and to see where they're at and to sit with them in the darkness and try to figure out what they need, what barriers need to be removed to help them get a better, stable life. Some people don't even have bootstraps to pull up. And we as CHWs get to meet them, whether you're in a doctor's office or at a health department like I am, or even home visiting or any of those things. You get the opportunity to really sit by someone and help remove those barriers. And that's why I really liked it. In my in this position now, I work I take all the calls from people who call into the health department and make appointments for them to come in. And I have an opportunity to sit shoulder to shoulder with them. And I actually have my computer set up very well for those who can come here, who have transportation, and sit with them so they can learn how to Navigate My Bridges right with me. So it's also an opportunity to teach those self-advocacy skills to them. It's really just a win-win opportunity. And so I did this for a long time. And when I found out that you could be certified, who wouldn't want to be certified? Who wouldn't want to take those opportunities to maybe even create a new funding stream for your agency? And to be able to have that credential. It makes people more employable. It makes people, be able to use those resources. Like Shannon was just speaking, I already received some modules to study up on, and I haven't, sorry, but I will. But there's so many things that you can do, and there's so many opportunities, so many different ways to assist people. And one of that right now in the UP is something that we haven't faced this barrier, this extreme as now is housing. Housing is terrible everywhere. And so sometimes you sit with people, you help them make those connections, help them look for housing, help them with rapid rehousing, help them, succeed in finding a home to keep families together, because it's getting very cold. We talked about snow maybe this weekend, and we have families who are looking desperately for housing. And there's somebody's brother, sister, cousin, aunt or uncle they're related to someone in our community, and they're often very vulnerable. And adults and children who really need our help. And so by connecting them with other resources, like for instance, calling the Rapid Housing folks, calling HARA, making those connections, teaching them how to make those connections, calling Salvation Army, having them call Salvation Army and have them ask and tell them what their needs are. And one of my recent experiences was that they gave them a tent, and the person was thrilled because they could own that tent. That was theirs now. And it made a big difference to those people. But even people who can't make rent payments, there's been a lot of changes because of COVID and expectations that people have. Since COVID, to like the reduction of COVID available funding, and to how like some of our greatest assets, like My Bridges has changed. So people went from not having to sign up or for My Bridges, it just kind of, like they have to renew it every 6 months or so. And they were able to, then they had to make that change. And then we have a new My Bridges. And so people needed help navigating that, and being able to help them navigate that turns out so easy, because some people learn how to do it all by themselves because they can use my computer and a keyboard, and they can sign up for themselves. It goes directly into My Bridges, so nothing's on your computer, and it's a wonderful experience for them. And My Bridges has changed so much. It's a much easier experience than filling out those paper forms. So those are just some of the reasons. And we do jail groups, so we make those connections, trying to remove those. I might meet people in jail, and I might find out what their needs are, to help them increase that stability so that they can, without that stability, nothing's going to change for them. Being able to kind of start sorting that out while they're still in jail. And so when they're coming out, they have some idea of like maybe where they can go, connecting them to those resources right away, and making sure that they're right on the right track. It's hard, and not everyone follows through, but we can do our best and to promote that. Also, one of the other things we do as community health worker, I've been able to do is a connection for treatment. People sometimes need that connection for treatment. You might find somebody and they're in pretty dire straits. Alcohol is a killer when people get older. It's a real killer. And many of our people in the Copper Country might use alcohol because it's kind of like part of our tradition. I think we have hunting camp, and we have all those raw things that we do, much like Wisconsin. So we do have to help. I'm sorry, I was distracted here. My phone was ringing. So we really do have to help those people make connections to treatment, and having them help make those calls, help making their own decisions about where they're going to go for treatment in Michigan, and helping them find that transportation and money for transportation, and making those connections as they go across the UP or downstate. So it's an honor to work as a CHW, and it's really a privilege. So thank you for that. And I want to thank my very special trainer. And we have this wonderful group. Audrey is a phenomenal trainer. We would really hash out things, and we would go off in directions, but she always brought it all back together and tied it. She's a good closer. So we really appreciated that. We were challenging sometimes, and she was very creative, and we had the most fantastic group in our training, and we had a fantastic trainer. We were just so blessed. It was really great. So, and we all our cohort is actually meeting every other month, the first Wednesday of the month, and we actually stay together. We email, and people say, do you have a resource for this? And our group is still really close. We had a phenomenal group, and because guess what? CHWs are really special people. They're people who love to help others and go out in the community. And so that being said, why wouldn't we have the greatest group of people together? So I'm just was really pleased, and I'm really thankful for the opportunity. So thank you.
Sue, you guys had an awesome cohort. You were the first cohort that our center went out and trained, and I don't think we could have picked a better cohort. And I can say that right now because we're not even through our second cohort yet. But you guys were just terrific, and I think you really set the bar high for us. Like, we have these expectations that everything is going to go that smooth now as we move forward with training. One of the things I wanted to ask you, first, I just wanted to say that I had worked at a federally qualified health center that had community health workers. And one of the things that we found was that because community health workers were community members, they became trusted individuals for the patients that we served. And what we found was that people were more likely to admit either what assistance they might need or what they didn't have with somebody who they felt was, at the same level as them, whereas they may not have admitted that to an actual physician or a physician assistant or a nurse practitioner because they were too embarrassed to admit something like that. What have you found, I guess, as far as being a community health worker and working with someone? Have you had a relationship where you can tell they're kind of feeling you out a little bit, maybe on a first visit, but maybe at a second visit, some of that trust is built up and they're more likely to open up to you? Like, what have you seen? It's hard not to open up to you because you have this great personality, but have you been able to actually see somebody blossom where, okay, now they're full-fledged telling you what's going on?
People, when they first meet you, and you try to make it a safe place for them, always like a safe place, and you try to create that rapport that they feel comfortable, and as you talk, they may share some of the things that they really need your help with, and as you meet them again, they begin sharing more things that they really need, they've had problems with. So yeah, I think they do just really, really blossom. I think we can find that with like some of our people who not had good connections, maybe people like who are very vulnerable, people who've been in jail, people who don't know who to trust anymore. And so they may be a little bit wondering, and wondering what your connection is and where, like what are they safe telling you? And so they feel you out. And so as they become safer and safer, they will.
Yeah, that's good. Kelly, I think you had a question.
Yeah, when we look at the need up here in rural communities, we have everything from cradle to grave kind of issues, certainly. And you've mentioned many of different groups that have needed it. Are there, in rural areas here, do people focus within a particular group, or do you specialize as a CHW so that maybe you're more focused on maternal or young children, or more focused on adults? Or do you just kind of like our rural healthcare providers just have to handle everything?
I think we just have to handle everything. Maternal infant health has been like my passion, but so now that I sometimes work with these people as when they were younger and with their families, I'm seeing them more, with their children growing up, they have an opportunity to come back, and they do, and I see them some more. And I even see, their parents, their grandparents. I see a lot of that intergenerational and have served many people in a family because I've been doing this for a while. But also, what's kind of new to me is the senior citizen. Not that I am one, but the senior citizens, I have a lot more of them, and some of them, we have people with disabilities too. So when I'm trying to help them, I let them type in their own things on my bridges and stuff and get that feel for how to do that and what comes next, letting them do that. And some people with disabilities or some people are a little bit shy, but almost everybody wants to do a little typing. And so it's really kind of fun to kind of engage people and let them, because people didn't always, there weren't always computers, and there was not always electric typewriters. And so some of the people that I serve, just have kind of missed that. But they kind of look at it as like, oh, maybe I want to try that. So you let them try, or I can do it for them. But it's just really great to connect with people and let them have an opportunity to become their own advocates.
Thank you, Sue. Your community is very fortunate to have you there. And I'm sure the people you help realize that, but thank you for what you do.
Thank you.
For listeners who might just be joining us, this is the UP Community Health Town Hall program. Tonight, our topic is community health workers, a growing occupation right now in the Upper Peninsula of Michigan, as well as at a national level. And next, we're going to talk with Audrey Surlis. She is a project manager and community health worker instructor here at the NMU Center for Rural Health. She's going to talk a little bit about, as an instructor, what's covered during training, how it's covered, and what she believes is the value in completing training. So thank you for joining us, Audrey.
Thank you, Elise. So when we're in training, we cover about 20 chapters over the course of training. We're moving through a lot of material. Some of my favorite topics are communication skills. We talk about motivational interviewing, cultural humility, ethics, empathy. We talk about advocacy, and we go over self-care, which I think is really important. CHW training primarily uses PowerPoints and a student workbook that was created by Everyday Life Consulting. The workbook, which I have here, has activities and has assessments that people do in class. And then to supplement the PowerPoints and the workbook, each student gets a textbook. We do a lot of group activities. We look at case studies, and we have a lot of open conversations about common experiences in the field. The NCHW course uses the popular education model. So there, in general, is just a lot of discussion and collaboration involved in the learning.
Audrey, can you talk a little bit about the actual class that we're providing right now? How long is that? How often do they meet?
So the CHW class we're doing now is for 6 weeks. It's twice a week, 8 hours a day. We do it with the grant funding, and we have 2 days that are virtual. So we do mental health first aid, and then we do ACEs training. Those are 2 virtual days, and those are provided by Everyday Life Consulting. But I or Judy will teach the instructor days.
I think the grant that we received for that has been just huge right now in trying to really increase the population of community health workers. It's normally around a $1,600 training typically, and right now we are offering this throughout the Upper Peninsula at approximately $250 a person to receive their certification. So there's a significant discount on this right now. We will have this grant for the next 2 years. And so we look forward to continuing to offer trainings in different areas of the Upper Peninsula, and letting that discount really, everybody should take advantage of that while they can, to get that certification. So Audrey, you've been training, and right now you're actually a student in the class becoming certified. What's your favorite part of being a trainer?
My favorite part is when a student connects with a concept that we're discussing and they bring in like a real world example. So I can see that they're not only understanding what we're talking about, but they're connecting with the material. And then most of the time when students bring in real world examples and talk about them, then the other students can understand a little better as well. And I love seeing that moment when a concept really clicks and someone can bring it into their workday.
I know you weren't expecting me to ask you this question, but prior to working here at the center, had you heard of community health workers? I'm just curious.
I hadn't, no. And my degree's in community health education, so I should have, but I haven't. And I think there needs to be much more visibility. So I'm glad that as a center, we have this grant where we're able to really promote this training because there's so much value in it.
And I think it's pretty obvious after hearing Sue talk that obviously Sue stays in touch with us, and we still talk about, new and upcoming things and how can we pivot, future trainings, maybe based on more information that they're learning. So we're always grateful for that. Is there anything else that would be good for us to share with employers right now who, it seems like everybody you've had in class so far already has been employed and is picking up the certification and the skill set, but we also want to try to reach people who may not necessarily be working in this avenue that are interested in being in this avenue, and connecting them with employers and being able to fill a niche right now that isn't necessarily being taken advantage of.
Yeah, I think for folks that are in healthcare services, this is helpful, but also public or social health services, people who work with the public in any capacity could really benefit from CHW training, just because of what it teaches: effective communication skills, empowerment. It's valuable for everybody, whether you're not. And I want to mention that I feel like CHWs are important in this upstream approach to approaching healthcare. They prevent health issues. They prevent issues in general. So it's really important to get the right training so that that effect can be magnified.
Audrey, as you're speaking about that with the other employers, is this something as a CHW that could be not a full-time job? I guess I'm thinking I have a project with another university, and we're reaching out to people, and they have, one of the ways they're reaching out to people is through a bookmobile. And the person who runs the bookmobile is really interested in offering different services along with some reading material to the people that they are visiting. And so is this something that someone could be a CHW where they're doing that part-time in addition to their other time, or is this really a full-time job because it is a skilled job, and skilled care to be able to provide? Is it something that that's your full-time job?
I think it can absolutely be a part-time position. And I think Shannon might be able to contribute a little more insight to that. But I think as long as you have that skill set and that certification, you can work in any capacity, whether that's part or full-time.
I've also thought about people who are in positions that may not have necessarily had any kind of formal training for some of the skills that you've brought up, and just the value that this can bring, to individuals who are already in positions right now that are faced with some of the things that you might be bringing up. Some of those barriers to care or barriers to other things like education, barriers to housing, and those kind of barriers, once those get removed, it's almost like the sky is the limit for people. They just need a little encouragement and support and, self-confidence. So I think that's really important.
Yeah, absolutely.
Is there anything else that you'd like to share at all, Audrey?
Yeah, so I work with Elise, and at the Center for Rural Health, we are going to be launching our UP-wide CHW network call. This is going to be a regional call for anyone who's a community health worker. You don't have to be certified to join it, but it's kind of like a support group that will meet quarterly to talk about different community resources, some challenges that anyone's been facing, some possible solutions, and just a general networking resource call that we're going to be hosting mid-November. And so you'll probably see more information about that next week.
Yeah, and actually, now that you say that, we'll probably add that to our webpage too, which is nmu.edu/rural health. We have a little section for community health workers, so we'll make sure to update that as well. Thank you, Audrey.
Thank you.
Judy Brugman is also a community health worker instructor here at the Center for Rural Health. And she's going to talk a little bit about community health workers at the macro level, the impact and the importance of connecting care within the community, is including the healthcare agencies and social service agencies. So welcome, Judy.
Hi, I'm glad to be here, Elise. Thank you so much. In my career, I spent about 25 years working with substance use disorder services across the UP. And so I feel like having CHWs at expanding the availability of CHWs within healthcare and social service agencies will almost certainly result in improved outcomes for the patients or clients that the CHWs are able to connect with and serve. Particularly with SUD treatment services, very often as individuals move between different agencies and or levels of care, the information related to their care needs may not move with them. And I feel that CHWs will strengthen the continuity of care by offering support and follow-up during that transition and over the duration of the care that the individual may receive, whether it's with the primary care office or with a treatment provider. Also, part of the role that CHWs will be able to offer is perhaps educational sessions that aren't offered by other staff at an agency. These sessions will often focus on social determinants of health. For example, they might be educational sessions such as topics on nutrition, chronic disease management, identifying community resources, and possibly other topics as deemed appropriate by the agency. A CHW might assist in identifying transportation resources, housing options, and maybe even helping to reduce food insecurity for an individual or a family. As noted, CHWs tend to identify resources within the communities that they work and live within. They attend health fairs, other community events to offer support for those in need of a multitude of services or resources. It seems as though some CHW positions are office-based while others spend time in the community. For example, at homeless shelters and food pantries. Recently, several UP health departments have taken delivery of mobile units. And as these become operational, I would expect that CHWs will be part of the team that go out into their communities to offer services via the mobile units. So I think the timing of the center being able to provide CHW training is perfect for the UP.
Judy, in the cohort that you're teaching right now, is there anything in particular that you're learning this first time around with the individuals right now who you're training? Because you get thrown into the middle of getting to hear all these stories like Sue was talking about, and these real life situations, anonymously, of course. You know, is there anything that you've learned as an instructor from your students?
Coincidentally, I had prepared my remarks before I heard Sue speak, but this is a testament to Sue's passion. My notes reflect that the individuals working as CHWs are passionate about helping people. That has shown through every single day. The other piece about this is that in our class in Marquette is we've got 16 students. So all of those individuals, none of them have the same position. They all hold different positions and different roles. So the title of CHW, the actual day-to-day role, can vary greatly. And a lot of that's going to be dependent on the provider type that the individuals work for. The learners, the students quickly engage to talk to each other about the types of work that they do, the types of resources that they might provide. And even within this course, we've seen a couple of individuals work cross-agency to try to improve access to care for individuals that they're mutually serving. And that's been really rewarding to be able to see.
That's pretty
One of the-
exciting.
It is, and one of the challenges that virtually every one of the participants has identified is that no matter how much effort goes into something, some of the resources just aren't available. And so talking about advocacy as a CHW, we've spent a fair amount of time talking about how different projects might be able to be initiated with advocacy from the CHWs, and even working within their own agencies to advocate for policy updates or additional programming to be offered within their agency. So that's been exciting.
That's interesting you bring that up, because it makes me think about, Sue basically talking about clients and patients learning how to be empowered. And at the same time, I think that training is really teaching CHWs how to empower themselves as well, and working in the system.
I agree with that. And I think that one of the things that the CHWs will be able to do is model that advocacy, and hopefully some of their consumers that they're working with and serving will see that advocacy and like you said, begin to be able to start to find their voice in being able to advocate more strongly for themselves.
Yeah, the other interesting thing I think is that, this is our second cohort for training right now. So we're still a little on the green side, but we're doing all right. I think of Audrey had, 8 to 9 students up in the Houghton area, and right now you have 16 in the Marquette area. And takes a little bit longer to build trust, the more people that you have around the table, and so we're learning size wise, what's different from that first cohort to that second cohort. But I feel very optimistic about the people that are around the table and the training and the conversations that are taking place. And when you hear Sue after going through that training and how tight knit everybody is afterwards, I think it's great that these individuals are meeting each other, because I think they will continue to be a safety net for each other in those communities. And the more people that we can get that feel that way throughout the Upper Peninsula, the stronger those communities are going to become.
I totally agree. And I think that it's already happening, that some of these learners are already connecting with one another to try to identify maybe additional resources, or if one of them has had difficulty trying to provide a certain amount of assistance, like housing, like you mentioned, is such a big challenge. They may be reaching out amongst themselves to try to be able to identify additional resources or resources that they weren't familiar with to be able to help an individual.
Yeah, that's great.
It
Thank
is.
you, Judy and Audrey, for the trainings that you're providing, and really for helping us learn, how to do this work. And we appreciate the grace that employers and students have shown us as we kind of go through this. Our goal really is to be able to increase, the access to care for people and improve their health and well-being. And to be able to provide this training right now at the regional level, I think is so important. And things will continue to move and happen, and politics will continue, and we'll go through the road of reimbursement, and this position is going to continue to develop. And I'm just glad that we're on the ride right now where we are and moving this forward, and can't wait to see where it actually takes us. So thank you.
Absolutely.
So for people just joining us now, this is the UP Community Health Town Hall Program, and tonight's topic is community health workers. We have one of our guest panelists, Leanne Espinoza. And Leanne, I've got to pull up your title because everything is so long here. Maternal Infant Health Program Manager and Deputy Public Information Officer at the Luce Mackinac Elder Schoolcraft Health Department. So welcome, Leanne. She's going to talk a little bit about her agency's role as a community health worker employer. So the fact that we have two health departments on tonight, I think that's great because you're in completely two different geographic regions of, the Upper Peninsula, and you may or may not be offering the same type of, role and responsibilities. So we look forward to hearing all about what's going on over in your neck of the woods, Leanne. Thanks for joining us.
Thanks for having me. I am sort of, I guess, the newbie to community health workers. I'll give you a little bit of background to how we got involved in it at LMAS. So Upper Peninsula Healthcare Solutions and Upper Peninsula Health Plan, several years ago, I think it was 3 years ago now, wrote for a federal HRSA grant to create a program called UP Mom. And the UP Mom program uses community health workers to support pregnant women and women with newborns up to approximately a year old who have substance use or opioid use disorders, or are risk for, or in the past have had. And those CHWs do a lot of what we would call kind of that wraparound care. So they will walk with a family, with a mom, through housing, transportation, linking to recovery services, if that is what the path they've chosen. So we were approached by them to work with them in hiring a CHW for Delta County, because our maternal infant health program covers Delta County, even though we are Luce, Mackinac, Alger, and Schoolcraft. So we hired a CHW to fill that position, and she began working with our families in need, and it worked out really well. And then we discovered that they only had funding to implement this program in Chippewa County, Marquette County, and Delta County. And then they had a different Blue Cross Blue Shield grant to cover the Western UP, which left out most of the Eastern UP. So the 4 counties that we serve, Luce, Mackinac, Alger, and Schoolcraft. It left out Menominee County, and it left out Dickinson and Iron County. And it wasn't a matter of not wanting to provide, it was just a matter of the funding. So back in, I think early December, we wrote for, at LMAS, another HRSA grant for neonatal abstinence syndrome to cover those counties in an expansion of the original UP Mom grant. And we were awarded that grant about 6 weeks ago now, I guess. So that grant then will build on that CHW work, providing 2 CHWs for LMAS, a CHW in year 2 for Menominee County, and in year 3 for Dickinson and Iron County. So we will be the supporters of that work and the fiduciaries for that funding. So that's kind of how we got involved in the CHW work. We also have a harm reduction program in our 4 counties, as well as 2 peer recovery coaches who recently, when they started, trained as CHWs. So we're really sort of embracing that whole concept at LMAS in our peer recovery and in our harm reduction, and then just in our recovery and general services that we provide.
Congratulations on your grant. That's terrific.
Thanks.
Yeah, that's going to make you feel really good.
There was no pressure.
Yeah. Hearing about, all the work that you're doing with community health workers, let me just say that I would love to follow up with a blog story that highlights some of the work that your community health workers are doing, and, completely open to how do we talk to other employers about, how they could utilize community health workers and help to advance some of the work for their clients and patients.
I would be open to that. Give me a couple months to get my next 2 hired and going, who will be participating in one of the rural centers trainings.
Yeah,
if they aren't already.
You mentioned HRSA, so that's Health Resource Service Administration at the federal government level.
Yep.
And incidentally, HRSA also had funded our UP WIN grant, which is what we received funding for to be able to offer this training. So I think it's great that the federal government, is spreading the dollars right now to really try to improve what's happening with the health and well-being of, people in the nation. And I feel really fortunate that our area is getting these dollars, to be able to do this work. So.
Absolutely. We really weren't sure when we wrote for the grant because it's a federal grant, so it's open nationwide, and we're just the little old UP, but they decided that we had a worthy project and we are going to take it and run with it and hopefully build it into something really great across the whole UP. Which is one good thing I can say at LMAS, our agency, our management, and our administration are really big on not only helping our 4 counties, but really supporting wherever we can support in the UP to help families.
Do you have an idea? I know that you're still embarking on all this right now, but as your community health workers start to get into the field of what you want them to do you have any plans on how you're going to measure the impact that they're making on the projects that you're giving to them?
So we do. We're building on that. It's not a fully formulated thing yet, but we're looking at it. I think we're going to measure the numbers, how they go in recovery, where, how many are we successful if they need housing, how many are successful in gaining housing and then able to keep that stable housing. I mean, there's a lot of ways that we're looking at being able to measure those things. The nice part about this program is the CHWs work will work and currently do in tandem with the 2 home visiting programs that we offer at LMAS. So they are going to be fully supported and supporting our maternal infant health program nurses and social workers who provide those Medicaid families with home visiting, and our Healthy Families UP program, which we actually have. LMAS supports the whole Healthy Families UP program. We are the fiduciary for that. So we support a Healthy Families home visitor that covers every county in the UP. So we have a lot of other data to pull because they will work in tandem with those home visitors. The same with our harm reduction unit and our nurse at LMAS.
Do you know, just out of curiosity, Leanne, do you know if the other health departments also have community health workers right now?
In providing this specific kind of community health work?
I'm just thinking, and I guess I could find this out myself if I made a call tomorrow, but I'm just curious, like because I know the health departments all talk to each other,
Right.
Are there community health workers down in Iron Mountain right now, over in Chippewa?
So Chippewa County they have Kyra. She's the community health worker. She specifically works with the UP Mom program. So She focuses on the same things we are. So Chippewa does, Marquette County does. Again, they have a UP Mom CHW. Western UP is a new program. And Sue, I'm not sure, Sue's telling me they have 3. I knew they had at least 1. So they have 3 at Western UP, and Western UP covers, Sue, correct me if I'm wrong, but Houghton, Farragut, Keweenaw, and Ontonagon. I missed one.
And Gogebic.
And Gogebic.
Yeah.
I always forget Gogebic. I'm sorry.
Yeah.
Oh, that was good, Leanne. I'm impressed.
And then Delta County, we had one. That spot is now open again, so we are hiring again for that spot for UP Mom. So Delta County will have again. So right now, those are the ones I absolutely know about for sure. If they have other CHWs working in other programs,
Sure.
I can't guarantee that. We do have our 2 peer recovery coaches at LMAS that work within our harm reduction areas. They are also CHWs, but they don't work specifically with UP Mom, but they will be in the future.
Yeah, I mean, tonight, this was a good example of the different kinds of roles they can work in and still be able to do their work as a community health worker.
Absolutely.
I know that we have a few hospitals right now in the Upper Peninsula, Marquette General, UP Health System Marquette, UP Health System Portage, and UP Health System Bell has been utilizing community health workers the last couple of years. The function they've been using them for primarily, I believe, has been in the emergency departments or the emergency rooms. taking a look at individuals who are visiting more frequently than is ideal for an emergency room, and starting to educate and address and identify individuals who may be in need of assistance, so that there isn't overutilization of emergency rooms. And so I'm interested to see how this profession continues to grow and how people can choose to use community health workers and really address all the different things, all the different areas that all of you are touching.
So Elise, I can tell you too, Upper Peninsula Health Plan, which is our only Medicaid health plan in the UP, has used CHWs for several years for like their client care and wraparound coordination, their care coordinators. So they also have several CHWs that they use through the health plan.
Yeah, and I know that Upper Great Lakes Family Health also has community health workers and has been using them for a number of years as well, which I've seen. Incidentally, I used to work there, and we saw when we had put a community health worker in one of the clinics, we saw a significant decrease in the no-shows that were happening in appointments. And so, we could see that value, even though you couldn't run a report and say, okay, what was the value of having that community health worker? So I think there's different ways to really measure that success and the impact that community health workers are making.
I think that we use a lot of like personal testimony too from clients that are willing to do that. And I think that in this profession with community health workers, personal testimony sometimes is even greater than like a data or a statistic or a number. When you hear that somebody like Sue or Judy or Audrey, right? I'm sorry. When they have touched somebody's life so much that they are willing to get in front of people and say, because of this person, I'm in a better place than I was a year ago or 6 months ago, and I'm going to be able to continue moving that forward. That is huge. And when they refer you to their friends, is also huge.
And we did have one of the listeners actually just chime in on our question and answer that also indicated that success as a parent with the social drivers of health or social determinants of health outcomes. And I think that's a great point. So thank you for making that point, Monica. So Kelly, any other questions from your standpoint?
I have one comment that I want to add in. I was at a conference just a couple of weeks ago, and some of you may have also been there as well. And it was a Michigan conference, and they highlighted one, and I apologize, I can't remember who it was. I believe it was downstate, but it was a health department that had put a CHW inside a factory, basically. And that manufacturing workplace was able to then see benefits from having that community health worker there in terms of reductions in missed days of employment, as well as retention of employees, and also for those individuals addressing all of those factors that you guys have been discussing. And so even looking at it from totally outside the healthcare systems, in this case, the health department was able to place the person in there, and I think they had a grant to do that. But really, we can see how it benefits our entire economy when we look at how much all these drivers really impact everything that we do.
Yeah. I'd like to just take a moment and thank all of our guest panelists for joining us tonight. It's been a pleasure having you on and talking about community health workers. I hope our listeners have been able to learn a lot tonight about this profession, and I look forward to staying in touch with all of you and really seeing how this profession moves forward. Thank you so much.